Hi, welcome to Dr. Vic's Academy. Today we will be talking about pharmacological treatment of dementia. Principles of treatment. Pharmacological treatment can be broadly conceptualized into three broad categories. Reverse or stabilize the underlying disease. Improve cognitive symptomatology, and treat behavioral and psychiatric symptoms associated with dementia. Reverse or stabilize the underlying disease. Vascular risk factors are putative not only in vascular dementia, but also in Alzheimer's disease. Thus, vascular risk factors should be assiduously sought for and appropriately managed in all dementia cases. Only a small percentage of potentially reversible abnormalities are truly reversible, most notably conditions such as depression and hypothyroidism. There is concomitant neurodegenerative causes such as Alzheimer's disease in many of these patients. Hence, when significant neuronal damage has occurred, treatment of potentially reversible causes often arrests the underlying pathophysiology but does not reverse the dementia. NSAIDs, cyclooxygenase 2 inhibitors, low-dose prednisolone, estrogen replacement therapy, high-dose vitamin E, statins, and omega-3 fatty acid have not been shown to be effective. Medications for improving cognitive symptomatology. Currently, the established modalities for dementia treatment are considered to be primarily symptomatic rather than disease-modifying in their mode of action. There are two main classes. Cholinesterase inhibitors, based on the cholinergic hypothesis, which states that many of the cognitive, functional and behavioral symptoms derive from an absolute or relative deficit in brain acetylcholine activity. And N-methyl diaspartate, or NMDA receptor antagonists, which protect against glutamate-mediated excitotoxicity. Cholinesterase inhibitors. In general, cholinesterase inhibitors confer modest improvement in cognition and global functioning of short-term duration, activities of daily living, and neuropsychiatric symptoms. There are currently 3 cholinesterase inhibitors regularly used. Namely, donepezil, rivastigmine, and galantamine. The side effects of the 3 cholinesterase inhibitors are broadly similar. The most common side effect is gastrointestinal, for example nausea, vomiting, diarrhea, anorexia, which is dose-related and transient. Although cardiovascular side effects, such as symptomatic bradycardia and syncope, are generally not frequent, cholinesterase inhibitors should be avoided in patients with significant bradycardia, sick sinus syndrome or cardiac conduction disturbances. Weight should be regularly monitored as weight loss is not uncommon. NMDA antagonists. The only example of NMDA antagonist is memantine. There is evidence of benefit in mild to moderate Alzheimer's disease and vascular dementia, but of a smaller magnitude compared with cholinesterase inhibitor therapy. The cost-effectiveness of memantine therapy in moderately advanced Alzheimer's disease remains to be established. Memantine is generally better tolerated than cholinesterase inhibitors. Common adverse events such as dizziness, headache, fatigue, hallucinations and confusion tend to be transient. Memantine should be used with caution in patients with epilepsy and renal impairment. How should I decide whether to start symptomatic dementia treatment? Cholinesterase inhibitor therapy did not delay progression to dementia nor confer any consistent cognitive, global or functional benefits in the pre-dementia stage of mild cognitive impairment. Thus, cholinesterase inhibitors are presently not recommended in the routine treatment of mild cognitive impairment. Because the costs of cholinesterase inhibitor and memantine therapy are not subsidized, the greatest challenge of whether to initiate cognitive enhancers resides in the cost-effectiveness, especially in the more severe stages of dementia where the benefit of costly symptomatic treatment is going to be even more marginal. Thus, treatment decisions regarding the use of symptomatic treatment need to be individualized for each patient, with a conjoint decision reached after careful discussion of the pros and cons of treatment. For instance, where financial resources are limited, the opportunity cost of employing a maid to look after a patient requiring help with activities of daily living may override the modest benefits of symptomatic therapy. Which modality should I choose? Once a definitive diagnosis of dementia has been made, the choice of treatment modality is dependent on two key factors. Etiology of dementia, which can be broadly classified into Alzheimer's disease and non-Alzheimer's disease categories, and stage of dementia severity. For Alzheimer's disease individuals, cholinesterase inhibitors remain the preferred modality in the mild to moderate stages. Memantine is an option if cholinesterase inhibitors are contraindicated, not tolerated, or if there is disease progression despite inadequate trial of cholinesterase inhibitors therapy. In the moderate to severe stages, although combination therapy appears to have the best benefit, the cost remains prohibitive. With regards to non-Alzheimer's disease etiologies, the choice of treatment depends on the underlying etiology. Cholinesterase inhibitor therapy is the preferred modality in vascular dementia, as well as the synucleinopathy-based dementias such as Lewy body dementia. While memantine offers a viable option in vascular dementia, it should be used with great caution in Lewy body dementia, since there are reports of worsening confusion and behavior with memantine therapy in this group of dementias. Conversely, there are reports of worsening behavior in patients with frontotemporal dementia treated with cholinesterase inhibitors. How do I monitor the benefits of symptomatic treatment? Patients who are started on cognitive enhancers should be assessed for cognition, mood and behavior, and function within 3 to 6 months of starting therapy and thereafter, at least once yearly or as clinically indicated. Stabilization or modest improvement above baseline may be observed with cognitive enhancers in the first 6 to 9 months, followed a lesser decline thereafter. During follow-up, patients should be assessed using clinical methods, via assessment of cognitive, functional and behavioral domains through interview with the patient and caregiver, and/or brief mental status tests, such as the abbreviated mental test. When a patient does not appear to be responding to cholinesterase inhibitor therapy, the options include increasing the dose, switching to another cholinesterase inhibitor, switching to memantine, adding on memantine, managing expectations. To avoid unrealistic expectations, it is important to communicate with the patient and his caregiver or family from the onset that the medications are not a cure. The medications do not work for everyone. The principle of 1/3 generally applies. 1/3 improve, 1/3 remain stable, while the remaining 1/3 deteriorate at a rate as if untreated. Although there may be a response in terms of modest improvement or stabilization, symptomatic therapy does not prevent progression of disease and cognitive decline will continue even with treatment. The medication will be discontinued if the patient does not respond after an adequate trial of 3 to 6 months.
Audio Jungle. Audio Jungle.